All right, good afternoon, everyone. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you so much for joining us for this webinar titled Total Case Management, Patient Navigation, Providing Great Care and Increased Revenue. LRHA is happy to host this webinar presented by Lori Tamayo Consulting. The webinar is being recorded and will be available along with a copy of the slides on the webinar recordings page of our website, and I will drop a direct link to that page in the chat here in a moment. Your lines have been automatically muted when you join. Please remain on mute to prevent background noise throughout the session. You can enter any questions that you have in the Q&A box down below, and we will answer all questions at the end of the presentation. After the webinar, you should automatically receive a survey in your internet browser. We do ask that you please complete that survey. It helps us to improve our future events and identify future education topics that might be of value to our members. And so with that, I would like to welcome Lori Tamayo. Lori has 30 years of experience in the healthcare field. She started Lori Tamayo Consulting in 2009 and has since helped with many startups for new facilities or service lines and helped many struggling healthcare facilities become profitable. She started her career as a nursing facility administrator and has worked in most every healthcare sector from long-term care to acute care. So thank you, Lori, so much for being here today, and I will hand off to you.
Thank you. Well, it's great to be here. I know in my career, when I was running my healthcare business, there was a period of time where a hospital district that I'd worked at in Dalhart, Texas, they needed help. They were really struggling. And I took the job as a CEO while having my business still operating. And I learned a lot of different things that were going on that made me create this case management program. And I love sharing this information because it's something that, yes, you can hire us to do this for you, but also there's so many of things that I'll be sharing with you that you can do yourself. And it did save that hospital in Dalhart and made it profitable for years to come. So some of the problems that I identified whenever I first took my role there was I had a 3% ED to inpatient admit rate, which is very, very poor. The average, national average for critical access hospitals should be 12%. 2 out of my 3 physicians, they weren't admitting, and my ED providers weren't admitting. I had ups and downs on the floor. I was having out-migration, and my clinic wasn't doing a very good job of managing the patient's needs and their follow-up care. And we weren't even referring to our own service lines, such as home health, therapy, swing bed, cardiopulmonary rehab, all the different programs we had, we weren't referring to from the clinic or from the ER. We had a lot of problems just tracking documentation and out-migration. Some of the programs that are out there, you know about it 90 days later because the out-migration programs that are out there generally flow with billing and those kind of things. And so tracking it in real time is something that's very, very important that we'll talk about. We didn't have utilization review. We didn't have benchmarks. We weren't coordinating with the business office. And we had the typical critical access hospital system where you had a case manager that had 5 other jobs. Therefore, the case management patient navigation piece wasn't being handled really well. So most of the places that we help, we've helped probably over 50 to 60 hospitals in the Texas area, and some in a few states. They generally are in the admit rate of 2 to 6%. Again, we want to be at 10 to 12%. I know that DHCHD, the Dalhart Hospital, went from 3% to 10% consistently, and we went from an average daily census of just 15 patients instead of just an average of 6. So when you look at that and you do the math and you know the daily rates you're getting under critical access, then you're looking at 1.5 million just in swing bed and inpatient revenue. And you are definitely taking better care of your patients because you're navigating them through the system. So why does this happen? Well, Sometimes doctors are just tired. Sometimes they just don't know. They didn't go to medical school to know what bucket to put a patient in, when to progress them, how quickly to progress them to different levels of care. And they don't know how to use Milliman's or Interqual software for the purpose of determining medical eligibility. Sometimes they're just focused on one thing and not the whole picture with a patient. Therefore, some referrals that are preventative in nature weren't being, sometimes just don't get done. And then just they've got the wrong model in place for their volumes. Some hospitals are fine having the clinic doctors be the hospitalist, but some systems, that is just too much for one physician to do, and you really have to analyze those volumes to determine if you're really asking a doctor to do too much. And so there's lots of different options. You can have a hospitalist, a hybrid hospitalist, ER type doctor that works with you. You can have telemedicine for the hospitalist role, or you can, of course, use your clinic physicians depending on how your volumes are. But if they're very high, you're asking a lot of that physician. I can tell you from my doctors, whenever I came in, I just said, hey, what's the deal? Why are we not admitting? And my physicians told me, two of them said, Lori, we go to the clinic from 8 to 5. We go over at lunchtime and around on our patients. And then if we have anybody we have to go see after clinic, we do that. So then if I get a call at 10 o'clock at night, I'm either going to send it down the road or send it home because I'm exhausted. And that really was the truth in that scenario. Sometimes it's just that they just don't simply know what will qualify a patient for OBS or inpatient. So that's where case management comes in, and I'm going to talk further about that here in a little bit. Knowing how to track referrals out of your system. If you transfer to a higher level of care, that needs to be tracked. That patient and that family need to be contacted and brought back into your system. We refer out to specialists out of our clinics all day long, but we don't track and follow up on those patients to make sure they come back into our system. It is really critical, and patients fall through the cracks. Not only does the hospital lose revenue, but the patients are inconvenienced, having to spend money traveling several hours to a larger town and missing work, and or elderly driving on a road that they don't need to be driving on because we aren't managing those referrals out, bringing them back in after the specialist is done. So we're going to talk about that a little bit. And also just referring to your own service lines. There's a lot of service lines that complement each other, and that's an easy thing to do, is refer to yourself. And it takes care of the whole patient. The patient's falling on a regular basis. Maybe they need physical therapy. Maybe they need home health. There's several different things that can keep that patient from returning to that ER over and over again. Some examples of referral pathways, which is what we create, and you can create too. If someone needs physical therapy, more than likely they might need OT. They might need cardiopulmonary rehab or respiratory rehab if they have any diagnosis like CHF or COPD. They might be appropriate for chronic care management in the clinic setting. They might need surgery if the problem persists. They might need pain management if you have that in your area. So there's a lot of different things that one referral can stem into other referrals because the patient could definitely benefit. And then, of course, coordination with the business office, tracking your utilization review with benchmarks, having weekly meetings and working those denials is incredibly important. So this is our model. And of course, you don't have to have a different case manager for each one of these roles. This just shows the roles of where case managers need to be. Many times with many hospital systems, it's 2 or 3 people. Some hospital systems can get by with 1, but generally the average for most of our hospital systems is 2, or they use our remote case management option to save money, where we just take care of it from the remote point of view. We have, of course, the ER. That's where everything starts. And then you have your inpatient and your swing bed case manager. Usually those are one and the same. And then you've generally got your clinic case manager that also can do some external case management as well. Now, if you have senior services, then that is a whole other type of case management where you generally have something built in there already for long-term care, SNF, home health, hospice, those kind of things. So I'm going to just talk a little bit about what is the purpose? Why do we do this? It's intentional and proper patient navigation. Number one, you're taking care of the patient and you're doing preventative versus reactive care, but you're also making a side benefit where the hospital gets the side effect of making money because you're doing the right thing for your patient. Your patients are more satisfied. You have less out-migration, less inconvenience for your families and your patients. You have fewer denials. You have proper status assignments. They're in the proper bucket so that these patients are getting paid for appropriately. And you have planned advancement through to swing bed. So you start with OBS, inpatient to swing bed, and the overall healthcare system is being utilized properly for that patient. So the key components are clinical decision support resources such as Interqual or Milliman's. It was designed by physicians. It's what used by the insurance companies. And you'll see that some insurance companies like Milliman's, some like Interqual, but they both are very similar. They have a decision tree type of software where you put in things such as lab testing values, diagnoses, and things of that nature. And then it tells you if you have one more lab test that is rated at this, it could qualify. If you give one more dose of pain medicine, it may qualify for OBS. And it helps you and helps you help the doctor make the right decision. Now, of course, you're not telling the doctor how to treat the patient. You're just letting them know what will help them qualify. And many times it's best practices, what it's suggesting you do anyway. Dedicated personnel, I can't emphasize this more. Having someone that is focusing on this process, having someone that is wearing 5 different hats, it's not going to work when you're trying to navigate your patients. And I will say it's like this. When you're navigating patients, it's almost like you're a private detective and you're watching where and what happens with that patient every step of the way. It's surprising how many problems you'll find from an operational issue as well whenever you are properly navigating patients. And then, of course, education and setting expectations with providers, with the C-suite, with nursing, and then communicating, making sure everyone is communicated with. We use a smart sheet that's interactive where everyone communicates. It tells us when to do our clinicals, when the business office needs to do something in regard to billing. It helps us communicate when there's a denial. It helps us communicate whenever a physician declines a referral. It might tell the C-suite what's going on. It's a really nice interactive communicative tool. And then, of course, the decision software, like I talked about, it definitely gives you a lot of different places to put your patient when they should move along. And whenever you admit a patient to OBS or inpatient, you're doing that decision-making software every day to make sure they're properly placed and when do we move them along. Also, you have your length of stays. You know, we help also, besides critical access hospitals, rural PPS hospitals. And your DRG, if you do not utilize that DRG properly, you sometimes go into the red. And by making sure we assign the patient appropriately and move them from inpatient to swing bed, that helps the situation to where you're not losing money. So I've talked a little bit about the different things that are needed and for sure tracking, benchmarks, having those benchmarks and that UR criteria that I'll show you here in a little bit, policies, procedures, protocol, referral pathways, dedicated staff, scripting for your case managers, and constant oversight. So in the ER, that realm, you can have a case manager. It doesn't necessarily require it be a nurse. It could be a social worker. It can be someone with a medical background that gets trained. It can be remote. We utilize remote and we provide remote, and there are other services out there that do remote case management. You schedule it at peak times. Generally, that's from 4 p.m. to 10 to 12 p.m., but it depends. Of course, you study where your volumes are highest. You utilize the software for the decision making, and then coordinating with the clinic and other ancillary services to make sure that that patient is taken care of. The proper follow-up visits are done in the clinic. The proper referrals are made from the clinic to keep that patient from returning to your ER. The goal is to stop the returns within 72 hours. I can tell you in the scenario and in many scenarios, after about 60 days, those almost go down to nothing. Because what's happening with this cycle of not taking good care of the patients or moving them down the road, or what happens probably 80% of the time is sending them home when they shouldn't even go home. They qualify for services. They come back. So the typical person, Miss Joan, gets sent home. She's 80 years old. She fell and she has altered mental status, and she's sent home by herself. Well, what happens? Well, she goes down the tubes, and 72 hours, 48 hours later, she's back in the ER, but now she's so bad off, she has to be transferred to a higher level of care. If we had properly managed her, admitted her at least for observation, since she qualified, we might have stopped that chain of events for her. And that's what happens is you stop those returns in 72 hours. Reducing uncompensated care by managing those patients properly, and doing ER callbacks to ensure that patients aren't having trouble, and also to increase patient satisfaction. So the med-surg area, utilizing your personnel, your ER case manager, your swing bed case manager, sometimes these can overlap depending on your volumes. Generally, what we find is your swing bed and your inpatient are one and the same. And the focus is transitioning from observation to inpatient, inpatient to swing bed. You're doing those decision-making software analysis every day, and you're communicating with your physician every day and your staff to make sure appropriate diagnoses are put in place, to make sure documentation is there so that the payers, insurance payers, will have the clinicals they need to approve eligibility. And then, of course, educating the patients and following up on all transfers out to the higher level of care. If you've transferred somebody out, try to get them back. And there's nothing to say you cannot call that patient or that patient's family, because that's a continuation of care if they've been transferred out from your clinic or from your ER to a higher level of care. It is your duty to check on them and make sure they're good. And make sure they know that you have services that they can take advantage of in your system, which makes it easier for them. And then the clinic model, following up on all specialist referrals. You know, it was shocking to me to find out, first off, that patients weren't getting set up with a specialist within 7 days and managing that process appropriately. But then no one ever called to find out what happened. And I can't tell you in my own model and then in hospital and in other hospitals how many times I've heard, we sent this patient out and we're sending out to orthopedics, or we're sending out to the heart doctor, and we're sending out to the wound care surgeon. And then if you actually call and talk to the patients, well, my orthopedic surgeon has me set up to go into rehab here in the bigger city. And you tell the patient, well, you know, you can do that here. Do you want me to set that up for you? Or you hear about someone that's doing therapy or wound care in the larger town and you provide those services. Well, if you simply make a phone call and let them know, hey, I'm checking up on how did that referral go? What's the plan for you? And then you find out maybe that doctor has used his typical referral patterns in his larger city, not by trying to not give it back to you, but just he's used to his referral patterns. You can retrain that physician, and you can also redirect that patient back into your system. That happens so many times, and it's a simple phone call. It's all it takes to say, what happened and how can I help you? Let's get you back here to do your therapy. You don't need to be driving an hour and a half on the road. Let's get you back here to do your wound care. Oh, you can do your swing bed here. There's no sense your husband driving back and forth to see you and visit you. We can make this all happen here. And then, of course, chronic care management. That is a wonderful program for people that have 2 or more comorbidities that are 65 and older. And making sure that you get those people on those programs and that they have every 90-day visits, because if they are generally having those type of comorbidities, they need to be seen and maintained every 90 days to ensure nothing slides away. And doing annual wellness visits. Those are very important for the elderly population, not to mention just the regular population. And then also looking at what kind of things could you maybe do telemedicine for in your clinic? What are we referring out to all the time? Where do we see most of our patients going? I know in several of our hospitals, we have implemented telecardiology and telediabetes dietitian management. We've also implemented therapy and also some different specialties such as teleneurology. There's some great software platforms out there that can definitely keep patients in town and help those patients not have to travel and keep everything in place. I can tell you with my physicians, sometimes they think, well, all the hospital administrator cares about is making money. With one of my doctors on the inpatient swing bed side, I noticed that he had not been admitting his patients into swing bed. And I asked him why, and he said, oh, home health can handle them just fine. And I said, well, home health's not doing as much therapy as they used to do. Are you sure, you think that's best? And he said, they're fine. I'm not having any more discussion with you. So I let that go, and I and my case managers tracked. And I believe it was 4 or 5 patients. We tracked them for the next 30, 60 days. Every single one of those patients came back into the ER and were readmitted to the hospital. So I went to that doctor, not to say I told you so, but I went to say, hey, I have this data I would like for you to look at. I know you care about your patients. I really think you ought to rethink your swing bed decision, because all your patients came back, and they came back in worse condition than they were when you sent them home. And he said, oh my goodness, the data speaks for itself. He goes, that's what I needed to see. He goes, I won't ever not admit to swing bed. You've proven it to me. So the data that is kept is very important, especially for some physicians. They need to see the documentation. Remote case management. This is a great option, especially if it's done properly. Of course, we offer it, but there's also other people out there that offer it. There's also your ER groups sometimes offer a hybrid of this, and there's other groups out there, hospitalist groups, that sometimes offer it. We're very focused on offering it 8 hours a day. We're on your whiteboard in the ER. We're on we're watching all your patients, running eligibility, inpatient, OBS, swing bed, attending your case conferences, and provide a monthly utilization review with benchmarks so that everyone knows what can happen. That's how we do it. Other people offer different levels, but we are available 8 hours a day, and then we go back through anything that happened during our time off throughout the rest of the day, and we show you missed opportunities from the ER that could have been admitted. We retrain those physicians during the time we're not there, and we help progress the patients throughout the rest of the system, and even help with the clinic piece. So sometimes it's a great way to save some money if you don't want to add that FTE with all the benefits and everything. Generally, you would save about 60 to 70%. You're paying about 60 to 70% of what you would pay a full-time employee. So this is the actual example of what happened at Dalhart. It was a 2.5 million net revenue increase. And why I show you this was actually my hospital that I implemented this in, and this is why this is so important. And you can see with the numbers, of course, swing bed was a huge swing, inpatient was a huge swing, but just look at some of the clinic stuff and the ancillary stuff in the hundreds of thousands of dollars. So when you look at this, it really makes sense for your hospital system. But the most important thing is patients were taken better care of. So when you look at maybe the little bit of expense that went into that 2.4 or that 2.5, there was some software, there were the case management. So we ended up at a 2.1 net profit when you pull the expenses out. That's the return on investment. And this happened very quickly. Honestly, whenever we go into most hospitals, within 90 days, you're seeing a return on your investment. And within 6 months, the whole system is operating a little bit differently. This is some of the success stories we've had just by implementing some of these programs. You can see 60% increase in the ED to inpatient admissions, a year-to-date increase of 30 observations in inpatient admissions. Our hospital number 3, 16% ED to inpatient admit rate, Hospital number 4, 140% increase in swing bed and 227% increase in swing bed in 9 months in their days. And so you can see the admissions went up and the days went up. Here's what we try to do is we generally try to give you, and I'll show you the reports that you get, and it helps everyone figure out what's going on in the system. But again, the patient gets taken care of better, and you can see it's full circle care. It's taking care of the whole person and all of their needs. And it is better continuity of care. That's really what happens. But we track certain things, and that's what's important, and you are required to do utilization review. We have the following items that we track, and I'm going to show you some reports. And you can also look at these reports and make them for yourself and track this way as well. It is a great way of keeping up with what's happening in your system. So this is one report, and there's several pages to this, and it actually has the benchmark that's saying, if we aren't hitting this, then why aren't we hitting it? And it goes through looking at your ER, and it looks at your ER admit rate, and then it has your benchmark, and then where were you at? So that you can actually compare yourself. If your admit rate is not 12%, which 6% to OB, 6% to inpatient, if your length of stay isn't 3.5 or around 3, what's going on? If your length of stay is less than 2 days, it's greater than 4 days for OBS, or for inpatient, if you're greater than 2 days, for OBS, you've got a problem. And so those are the things that we look at. You look at your length of stay in OBS, in swing bed, your length of stay, 14 days. If it's less than that, what's going on? And then the number of admissions to swing bed, the number of admissions to OBS and inpatient. And these are some benchmarks just tell you this is sort of where you ought to be. You should have less than 20% of your patients staying 14 days or less in swing bed. Most of your patients that were in OBS should move on to inpatient. Most of your inpatients should move on to swing bed. And that's just the standards. And if you're below that, then you know you have an issue. Orders compliance, H&P compliance, of course, your readmission rate should be less than 14%. Your return in 72 hours should be less than 10%. Your code 44 should be less than 20%. And just looking at your admissions and looking at the provider utilization is extremely important. So if you look at your provider's length of stay in inpatient, you can look at that and know Dr. So-and-so's doing this, Dr. So-and-so's keeping patients too long, Dr. Jones is keeping patients too short. You can look at swing bed utilization. How long are they keeping their patients in swing bed? And what is each of my providers' ER admit rate? What's going on there? And you can actually sit down and have a conversation about what is happening. Also, 30-day readmissions. We look at that and we actually determine, was there anything that needed to happen different? Here's the patient, here's what happened, here's what the issue was, and if there was a doctor involved issue or a nursing involved issue, it's described there. Sometimes we've found some discharges happening at hospitals because nurses just simply didn't want the patients on the floor, and they were calling the doctors saying it's time to discharge. And the doctors were doing it because they didn't want the nurses mad at them. We've had that happen at hospitals. Sometimes we found the resistance to swing bed or skilled nursing in hospitals because the the nurses just don't want to take care of elderly long-term care type patients. And what we've put in place in those scenarios is let's add a nurse aide to the floor. It's not very much money, and that helps break that argument that nurses are having. They don't have to feed them. They don't have to bathe them. They can still be the nurse, but the aide will take care of the stuff that they don't want to do. So also missed opportunities for all of our different areas. You know, what was the condition? Who was the provider? What was the payer source? And then why could they have been admitted? What was the possibility that we could have admitted them under? Did they qualify? If they did, then why did that doctor not admit? Why did we not take that admission? Were the nurses on the floor saying that they were at capacity? that they were past their acuity rating. Is that really the truth? Do we have a problem? Do we need to have a house supervisor be called? Do we need to call the CNO before you can decline an admission to the floor? There's a lot of things you start finding out that are happening on the reverse end that you don't realize whenever you start watching these missed opportunities. And this comes out every week, the missed opportunities. The other part of the report comes out every month. And then just looking at denials, knowing what is contributing to these denials and why. Missing information is very simple. Medical necessity not being met. You'd be surprised how often that happens just because no one's got their eye on the ball with a consistent case manager. The prior auth not happening like it needs to. Providers out of network, duplicate claims, coordination of benefits. These are all things that need to be followed in our meetings with the business office and the case manager. And you look at bundling and you look at services that have already happened. You got a patient that's being seen at home health and being seen by the clinic on the same day. What's causing the mistake here, the duplication? Exceeding timely filing, that's totally not necessary. That's something that can be easily overcome. And then just best practices to combat denials, keeping the process organized, making sure that you've got your communication in place, who's submitting the clinicals, who's submitting the authorization, do the diagnoses match the documentation and what's being billed, acting quickly and establishing a team. That is the thing on denials. And there's a few more slides on just how to do performance audits, verifying patient information, learning from previous rejections or denials helps put processes in place quickly. And that's what we look at as a team with case management. Meeting deadlines and having meetings on a weekly basis just to be sure we're on top of the patient flow. So some of the competing agendas you'll find when you try to implement some of this process is the ER mentality. Many times we would get providers that were from larger hospitals that were ER providers, in the urban area. Well, of course, in the urban area, you're trying to push patients out. You don't have beds. In the rural area, you have beds. And if the patient qualifies, why send that 80-year-old home by herself if she qualifies for observation? So many times when I do a free analysis of ER and inpatient OBS, what I find with the ER is it's not sending them down the road to a higher level of care that's the problem. Most of the time, it's the patients getting sent home that's the problem. That they would have qualified and we would have taken better care of them, putting them at least in OBS and then progressing to inpatient. But many times your ER providers have that mentality of treat them and street them. That's what they're used to. That's what they're trained to do, because in urban areas, that is really what needs to happen because of sometimes their bed limitations. And then physicians and physicians groups, they are operating long shifts, there's maybe too much volume happening. And then they focus on just one thing, not the whole person. Many times they just focus on the one problem versus the whole person. And then, of course, ER staff and medical staff just aren't fully educated on medical necessity criteria. That's not really what they were trained for. Insurance is what not they went to medical school for. And then discharge planning, the employee culture, sometimes patients want to go home. They don't want to stay in swing bed. They want to go back to their nursing facility. They want to go back home. And talking about why it's important to stay and why it's important to be in the hospital and get that dedicated care is very, very important. And knowing how to have that conversation with patients and families and physicians to say, look, they have a higher nurse to patient ratio than they do in the nursing home, and they certainly have a higher ratio than having home health come in twice a week. This patient needs to stay and do therapy and get their feet under them. You think about, if you've been sick for a week or so, think about you as an average person, me in my 50s. It takes me a day or two to get my feet underneath me. Well, can you imagine if you're in your 80s? It might take a week or so if you've had a problem. And then just the employee culture. I can't tell you the number of times a swing bed program has been implemented, and we've really had to work on the culture of the hospital nurses to be willing to do swing bed or skilled nursing. Again, we offer that nurse aid a lot of the times because it's a low cost alternative to help the nurses not complain about the types of patients they're getting. But let's be honest, fewer patients mean less work. And I think sometimes nurses have PTSD about that one time that they got overwhelmed and they were understaffed. And I think putting things in place like on-call situations, backup plans, if that does happen, putting those things in place help with those arguments that you get. You can do this program and do a lot of the things that I've shown you. You can hire us to do the program. You can have us just do your remote case management. But the main thing is if you do this on your own, know this, that it takes daily monitoring and attention. You've got to have a dedicated staff member. You need to know the politics of the program. And I'll give you a little example on that. You need to know that, like with my doctors, my three, one of them said, nope, I'm not going to let your hospitalist admit. The other two were like, I want to let him admit all the time. So with the one doctor, I said, okay, well, if they qualify and we call you and you choose not to admit them, then the hospitalist is admitting them. So that's really, it's really, that's the plan. If they qualify, you don't want to admit them, you have the right of first refusal, but if they qualify, they're getting admitted by you or the hospitalist. And he agreed. He said, okay, call me, I'll admit them. And the other two doctors, they had some patients where they were like, we'd like to know there's some patients we want to take care of and we'll come in, but most of them we're going to let the hospitalist do. And so just knowing the politics of that, knowing how to navigate around it. Sometimes it's putting a telehospitalist model in where the doctors still see their patients in the hospital, but after hours. And in the middle of the night, the telehospitalist puts them in bed until the doctor gets in the next day. It's a little bit of a negotiation whenever you start putting this in place with what will your medical staff do and how can you support them, but also how can you get to where you're not sending patients home because the doctor's tired and doesn't want to deal with it in the middle of the night. So there's a lot of hybrid models you can do with that hospitalist program and still keep your doctors happy. And then, of course, you've got to refine your program and make sure you're communicating with your doctors like they like to be communicated with. Some like the HIPAA compliant text, some like using the EHR, some like phone calls. Making sure you communicate to everybody in the way that they're going to communicate. If they want a piece of paper in each one of their charts that tells them the plan for this patient and that's what that doctor likes, then that's what we put in place. It just depends on what's going to make it work smoothly. And then don't just do bits and pieces, do the whole program. It takes the whole program. Drive the bus. And just, even if you hire a case manager, you as a CEO or a CNO must stay involved. You should meet at least a couple of times a week and go over your numbers and figure out what's going on and make sure it's working. And you should meet with your medical staff and let them know the numbers as well. They get a little competitive when they see that somebody's got a better admit rate. One of their colleagues has a better admit rate than them. So my last slide here is just we would provide a free analysis of anything. We can look at your ER, we can look at your inpatient OB swing bed, we can let you know where your problem areas are, and generally it doesn't take too much time. We usually look at a couple of months worth of your data and then provide you with a report of here's your missed opportunities that we see, here's your length of stay issues. And it's a very cursory review, but it does provide a wealth of insight. And I will end my presentation and open it up for any questions.
All right, thanks so much, Lori. So we don't have any questions yet, but we'll give just a minute in case folks are typing. And while folks are working on that, I'm going to go ahead and put the link to the post webinar survey in the chat, and it should automatically open for you in your internet browser as well when you exit the webinar. Just give a few more seconds to see if we get any questions.
And feel free to put my email in there if there's any questions. We love, honestly, I've been in rural healthcare for years. I love helping people. I've had some people call me and just say, look, I'm doing this on my own, but I have a couple questions for you. I'm happy to answer those. We help people. um, it comes back to us in the long run. So if you're trying to implement this yourself and you have a few questions, just holler at me, holler at us, and we'll be happy to answer your questions and get you started in the right way. It really does help if you do good patient navigation. It helps your hospital system. And that's what we're about, is helping rural healthcare. I can tell you that if my hospital had closed down, it would have devastated that community. And this program really did help it, and it's helped so many others. So anything we can do, just feel free to call us or email us.
All right. Well, it looks like we don't have any questions. So thanks so much, Lori, for presenting today, and thanks everyone for joining us. Please do complete the survey. Like I said, I put the link in the chat, and it should automatically open for you when you exit the webinar. The recording will be available on our website within the next couple of days. And as always, please feel free to reach out to us at LRHA if we can be of any assistance. And thanks so much, and have a wonderful afternoon.
Thank you.
I thank you.